I can't emphasize how important it is to have a good relationship with your neuroradiologist. And if you don't, you really should, because they're your best friends and they're working in isolation. So the more information you give them, the better. I'll also mention, please look at your own images. It's how we learn, right? Or we'll catch stuff that they didn't see because we have the clinical story that they don't have as it goes through. So Craig, do you have my pictures there? My vignette? Well, while I'm waiting, I'll just ask you a question. Somebody asked a question that if you have an MRA for stenosis vasculitic problem and you're treating somebody, how soon should we image them after treatment? I know you showed the syphilis case. Is there a time that we should image afterwards?
I would say probably based on their symptoms, right? So imaging tends to kind of lag behind symptoms. So I would want to see, if their symptoms have like improved or resolved before you image again, because sometimes, like I said, there's a lag between patients improving and the imaging findings improving.
Okay. So I'll go through a vignette here. So why can't we all just get along? There are two famous feuding families in the U.S., not the Bidens and the Trumps. Who are they? Hatfields and the McCoys. Good-looking group there. Everybody's got a gun. So what is the neurologic link between these two families? Why all the aggression? What's that? Anybody know? What's this tumor here that? So we have a mural nodule with a cyst in the posterior fossa. Jenny actually mentioned the disorder. What was that? So that's a good guess. So if this is a child, pilocytic astrocytoma, excellent guess. If this was supratentorial as well, pilocytic would be, but this is a hemangioblastoma. So classic picture of hemangioblastoma with a mural nodule with a cyst associated with it in the posterior fossa. So what genetic disorder is associated with this tumor, where you can see them in the spine, multiple in the brain, you can see them in the eye? Jenny mentioned the disorder. Anybody know? So von Hippel-Lindau disease, I always remember chromosome 3, von Hippel-Lindau. Autosomal dominant disorder, it's a horrible disorder in that you can see multiple hemangioblastomas, brain, spine, retina. These people get into trouble when they're very young as it goes through. So what's the link between VHL and the feud? Why are these people angry? What do you see here? What's this? Oh, and what happens if you have pheochromocytoma? Right, catecholamine release. So this is a pheochromocytoma, increased incidence of pheochromocytoma in von Hippel-Lindau disease. And the McCoys actually had a history of VHL. So it's thought that the bad attitude is related to the catecholamines, easily angered, all the fighting and shooting. I'm not sure how much of that, I mean, all this is true, they did have this, but whether or not it really caused the anger or not, I don't know. But it makes for a good neurologic story. So we published a paper just over a year ago. Dr. Wan was one of our fellows at the time. And the important issue here is there's a new medication out called belzutifan. It's a HIF-1 alpha drug, and it's used to treat VHL, which is wonderful because multiple surgeries in the posterior fossa, radiation in the posterior fossa, wears people down like you can't believe. So we now have a drug that we can use and can at least stabilize or improve. And if I had time, I'd show you a lot of pictures here where you can have improvement in the swelling in the tumors. Just like Jenny showed the picture when they treated the patient with a low pressure and the Chiari got better and the chordedema got better, we see the same thing when we give this drug. So Jenny, I'll ask you another question. If you have a question, go to the microphone. If not, I guess we'll be done sooner. But still out there, I have people come to me and say, man, I'm claustrophobic, I need that open MRI. Thoughts about doing open MRIs or less than 1 Tesla MRIs? Do you want to comment on that? I could tell you what I think about it, but what do you think about it?
We actually, I think among radiologists, we're always going to say the higher the field strength, the better. And that's just because, we can see a lot better contrast resolution the higher magnet strength we have. It also depends on what you're imaging. Like if you're imaging like an MSK thing, like an elbow or a knee, you might be able to get away with a lower field strength. But for detailed structures like the brain, if you're looking for something very specific, I always say it's the higher the field strength, the better results you're going to get. It's kind of like, garbage in, garbage out,
Yeah, and the other thing that I would say is that, again, I think it's true, right? You have to ask yourself, what is it that you're imaging and how important is it? And I will have a conversation with people, and then the question is, should you put them under anesthesia to do the imaging and do good imaging? The other thing that I'll point out, and I talk to patients about this all day long, and I show them their images, is that oftentimes, we'll have someone that will have a post-contrast T1 axial GAD image and it has 13 images on it. So it's very thick slice, and, they go, oh, well, it only took me, 3 minutes to do the imaging. It's not exactly what we want, right, as we go through. So, I think if you really need volumetric imaging, this is why it's good to talk to your radiologist and make sure you're getting volumetric imaging on your patients. And I'll go to my neuroradiologist all the time, and I'll say, this is the scan I have, this is what the problem is. What actually should I be ordering on this patient? And they'll say, boy, you should probably do a skull-based vibe protocol with a KISS sequence and make sure it's all volumetric. So any comment on that?
Yeah, and I was going to say that there are newer imaging techniques, and we've actually been able to decrease the amount of time for our protocols with the same, without too much sacrifice on spatial or contrast resolution. So we've been able to kind of shorten through the use of AI and newer imaging techniques, a 4-minute scan to like a 1.5-minute scan. So all these are in process and they're taking place. So it's good to be aware that, maybe what might have taken like 45 minutes to image back then, now we have newer imaging techniques that we can kind of condense that into a 25-minute scan, which might make a big difference for a patient.
Yeah, don't be okay with the status quo, right? Look at your imaging. See if your center is giving you what you need. And if not, you need to talk to them. As you can see with Jenny, what she presented here, I mean, the Elucerin gadapiquinol, is just new, and we're in the process of changing all of our stuff over to the gadapiquinol. And not only is it better imaging for us, it's better for the patient. And I remember in the day, what's your creatinine, what's your clearance, what is it going on? And this has really become at our institution a non-question, right? It's really a non-question. Even people on dialysis, it becomes a non-question. So if you're still in the dark ages where you are and you're calculating GFRs on everybody, you need to chat with your neuroradiologist about these things. Yeah. The field is evolving as we move forward, and
yeah, and I absolutely
advocate for yourself.
Agree. Sorry, I didn't answer your other question about, so we like to tailor our protocols to what specific question you're asking. So like Dr. Stevens was saying, if you're looking for a cranial nerve palsy or something, we will tailor the sequences to look specifically at the cranial nerves. So that's just another example for why it's really important when you're ordering something to keep your radiologist in the loop, because they know what you're looking for. They can tailor the protocol to find it.
The most important thing that I learned today is I think that Jenny's a better neurologist than I am. You seem to have a very good handle on all these disorders, so I'm very impressed. I'm going to start expecting a lot more out of you. I may have you come examine a few patients as we go through. So does anybody have a burning question? If not, we'll wrap it up. I don't see anybody running to the microphone. I think everybody's tired and they want to go outside in the heat. But again, thank you very much, everybody. I know the virtual people are still on. It'll be available for you for a couple of months so you can relive all the joy and the things that you may have missed when you just had to go look at a monument for an afternoon and you couldn't enjoy your time with us. But next year, mark it on your calendar if you're interested. We, again, usually try and do it the first weekend in August. Last year, we did it a week later just because of a wedding, but it'll be at that time. And again, please just be very honest with your input. We do try to make changes, make things better, but I appreciate everybody's time. Bobby and I, thanks again to Bridge for all she does. The AV support has been wonderful as always, and appreciate all the support and help. So safe travels home for everybody, and we'll see you next year. Thank you.